not gone anywhere. So in this case, you've got a stable bag really because of capsular tension ring in place, but you've got that which is strand. This is an old video showing the actual use of a 23 gauge cutter. They are much larger, bulkier, autoclavable. This came with a Sovereign compact machine, requires a 2.8 incision, and because the irrigation and aspiration are not dissociated, you see the forces oppose each other. I'd like to touch upon, is there any role for scissors vitrectomy, especially for surgeons wherein you are still doing SICS and don't have a vitrectomy unit. This patient had a zonular dialysis for which a CTR was put, and at the end of which an iris sweep showed you that you actually have a peak pupil. So with angled varnish, which is sharp, which is properly autoclaved, sealed, ETO'd, it is safe to still today do a proper and thorough anterior vitrectomy should you not have a vitrectomy unit with you. At least we should know how to do it, right? Now, you may think that it's just a strand, like I'll show you in this case. So at the end of putting in the lens, we noticed that there was a peaking of the pupil there. Since there was no obvious PCR, I thought it was a zonular dialysis. Clearly, there was a peaked pupil and there was a strand of vitreous which is now cut. At the end of cutting that little strand, it's always good to put in some pilocarpine and see what happens. Why I'm showing you this is so that you understand that in intraocular scissors does not allow for an effective vitrectomy. If at all it has to be scissors, it has to be angled varnish. Putting in triamcinolone shows you that it's a lot more than a vitreous strand. Now, under viscoelastic, because I want space for my instrumentation, the vitreous is first cut from the wound. I approach the vitreous always from the opposite side to gain a little more access to the vitreous. And you can see in front of your eyes all the triamcinolone stained vitreous getting cut. We cut it always at the pupillary plane. And at the end, that peak pupil does come down, right? So some things might be slightly repeated, but there are a few points I'd like to make. This is a patient who was seen on day 1 post-operatively with disturbed vitreous in the anterior chamber. So you make incisions large enough to allow for your cutters. With a 23 gauge cutter, 23 gauge MBR is enough. Again, always stain with tricot, because that shows you exactly how much and that you don't end up, missing any vitreous. So here's the strand. In fact, there are 2 strands here. I put in some viscoelastic. And when you talk about cutting an isolated strand, I think, and this is another important point, sometimes I find with a 23 gauge cutter, tilting the eye towards the side of where the vitreous is prolapsed to gain access gives you a little more, access of going and cutting the vitreous. Remember that we are not going to use a vitrectomy every day. This is a cutter that has been used off-label, ETO'd, reused and reused. There's no way when you reuse a cutter, you know whether it's going to be sharp enough or no. So it would be preferable, you can see here, I'm going on cutting, I'm doing it correctly, but it's just not cutting. So you should aim to use a new cutter each and every time. You're not going to use it that often. You want to have an effective vitrectomy. All strands need to be cut not nearer the incision or in the middle of the anterior chamber, but at the pupillary plane itself. Now, what if you've got a blob of cortex floating around in the anterior vitreous? Sometimes at the end of the surgery, we go behind the IOL in the cut eye mode, only the cut eye mode, to remove either some bit of vitreous or some cortex. Now, at that point, you don't chase this cortex that's there, but should it come to your port, you can just keep cutting it and aspirating it. It saves you referring it to the VR surgeon. Now, coming to the proper automated anterior vitrectomy. Now, this patient is a case of a polar cataract, and at the end of nucleus management noticed a big opening in the PC. The aim of using triamcinolone is to stain the vitreous in the anterior chamber because it sticks, it doesn't stain it actually, it sticks to it and delineates it. When you want to cut the vitreous, you have to go in the cut eye mode. I would advocate using a cut rate of about 1200 to 1500 and a vacuum of about 150. Make sure that the vitreous is cut from all the incisions, not just one of the incisions, but all the incisions. Then the source of irrigation is introduced into the eye, and then the cutter from the opposite side. we proceed with the vitrectomy in the anterior chamber, you have to ensure that the cutting tip always is in your view. As long as you're seeing what's happening, you are in control. Make sure that your tip doesn't face to the side where you can accidentally damage the pupil or the anterior capsule, nor the posterior surface, because that's not what you're aiming to clear any which way. And then you cut the entire vitreous in the plane of pupil. Once I'm done with cutting it in the plane of pupil, sometimes I go in the area of up to the level of the PCR and I cut there as well. You have to make sure that you have that much control that you do not ever endanger the anterior capsule, because that's going to be your support system for placing the lens. Now, in this case itself, I'm using a 23 gauge cutter, but there's a very thick epinucleus there. So what I need to do is, I do not need any vitrectomy, that is cutting of the cutter, to remove the epinucleus. So I now go in the IA cut mode, wherein I use the same vacuum, but the cut rate is down to only about 400, which comes up right at the end. Sometimes in a very, very thick epinucleus, I may need to use a little bit of cut at the end of the aspirating it into the center to aid its appropriate aspiration. And I think it's safe to keep your aspiration what we would do during IA itself, because we are familiar with pulling on the cortex with of about 250 to 300. You can't always define what your vacuum needs to be. Okay, so if you have shallowing of the anterior chamber at any point, then you need to reduce your vacuum and or increase the bottle height. You decide what the vacuum needs to be, right? Decrease the bottle height or increase the bottle height or reduce the vacuum to maintain your chamber. That should be your gold standard. Now, in this case, there was a rent in the beginning of the polar cataract, and it's a very soft nucleus. I just did a little vitrectomy in the center. Then I went in the IA cut mode, and watch, while doing a viscofluid exchange, I'm only using the aspiration mode. This is a 20 gauge cutter, which made it easier for me at that point to just merely aspirate that entire cortex. Now, you can afford to be in the IA cut mode after you've cleared all the vitreous, should there be any in between. I think this is just another important point that I would like to highlight. That is one of viscofluid exchange. Let me explain to you in this case. So you can see that there's a large rent. Because there's no vitreous disturbance, the surgeon goes in the epinucleus mode and aspirates the entire cortex. Now, at this point, if I just come out, the vitreous would have herniated. So instilling some viscoelastic before bringing the source of irrigation out of the eye always tends to compartmentalize the vitreous. And this is the last part of my talk. The importance of understanding why we use triamcinolone and how much to use. It always should be non-preserved. It's 40 milligram per ml. You take 0.4 milligram in 0.1 ml and still dilute it further. The important thing is to stain only the anterior vitreous, anterior disturbed vitreous. And when you're cutting the vitreous, you know, the funny thing is that every time you see that trichord floating around in the anterior vitreous, we wait for it to come. We think we need to sit and cut that vitreous as well, the vitreous or the trichord or whatever that is. So you limit how much you inject into the eye, because all you want to do is work in the anterior chamber. So even here, I've cut. I'm fairly certain that my vitrectomy is clear. But then there's that tendency, you know, there's more coming, there's more coming, there's more coming. You don't need to keep cutting just till all the trichord is then aspirated. So limit how much you really need to use. I hope that makes some sense here. So I'm just showing that here in this particular case. And once you're done with your vitrectomy, once more you do a viscofluid exchange, then get out of the eye, and then proceed with the next step of putting in the IOL. So here again you can see that the tear seems to be fairly well controlled. And finally, each of us needs to know what is the end point of a well-performed vitrectomy. You need to have all the prolapsed vitreous that is cut with the cutter facing you with the correct settings, a new cutter. Then the rest of the tags are hanging onto the incision. Those cuts need to be removed, those tags need to be removed, and the pupil should be round and central. Thank you very much for your hearing.